אהלן, שלום לכולם. תודה שבאתם היום ונרשמתם לוובינר המיוחד והחשוב הזה. אני גולן רוטרולץ, אני עו"ס קליני במקצוע שלי ומנחה קבוצות, ומנהל של עמותת הפחתה אחראית, מייסד שותף ביחד עם איתי אהרון זיו, ועוד כמה אנשי מקצוע נהדרים. אנחנו גאים היום לארח שני מומחים עולמיים בתחום הזה של הפחתת תרופות, אז אחד זה דוקטור מארק הורוביץ, שמצטרף אלינו מבריטניה. Thank you Mark for being here. והשני זה פרופסור פסח ליכטנברג, שהוא שלנו מישראל. תודה פסח. Thank you both for your time and your effort to make this meeting cool. למי שלא מכיר אותנו, אז אנחנו עמותת הפחתה אחראית, עמותה בתחום של בריאות הנפש, שמסייעת לאנשים לקבל החלטות מושכלות ואחראיות בקשר לשימוש ולהפחתה של טיפול תרופתי פסיכיאטרי. המטרה שלנו היא למנוע סבל מיותר שנגרם כתוצאה מהפסקה לא אחראית של תרופות, ולעזור לאנשים במצבים שונים, באמצעות מידע שמבוסס גם על מחקרים וגם על ניסיון החיים של אנשים שהגיעו מהמקום הזה. הפעילות שלנו היא מבוססת על שלושה דברים מרכזיים. אז אחד זה מרכז הידע, אנחנו מהווים מרכז ידע לכל הנושא של הפחתה אחראית, מתרגמים חומרים, עושים מחקר שהתחלנו ממש עכשיו, מביאים ידע עדכני מהעולם וידע מהימן וידע ביקורתי, בקשר לשימוש ולהפחתה של טיפול תרופתי. הדבר השני זה המרכז לסיוע וייעוץ. אנחנו בעצם מהווים איזשהו מקום מפגש לאנשים שרוצים להתלבט, לחשוב על הדבר הזה, בין אם באופן אישי ובין אם בקבוצות וירטואליות שאנחנו עושים בפייסבוק ובוואטסאפ. הדבר השלישי שאנחנו עושים זה מרכז להכשרת אנשי מקצוע. אנחנו בעצם עושים סמינר מדי חודש לאנשי מקצוע שנמצאים כאן, זה רלוונטי, שבו אנחנו מכשירים אנשי מקצוע כיצד לדבר על הנושא הזה עם המטופלים שלהם ואיך לכוון אותם בנושא הזה, כדי שהם לא יעשו טעויות שיגרמו להם הרבה סבל. אז זה בגדול הפעילות שלנו. אנחנו מתרחבים וככה עושים גם את הוובינר הזה למשל היום. לפני 3 חודשים קיימנו כנס גדול במכללה האקדמית תל אביב יפו, שהגיעו אליו סביב 200 אנשים, שהיה מאוד מוצלח. והמטרה שלנו היא לסייע לאנשי מקצוע, לנהל שיח מקצועי עם המטופלים שלהם. אנחנו יודעים שבקהל היום יש גם אנשי מקצוע, גם אנשים שמתמודדים עם הפחתה, מטופלים, גם בני משפחה וגם ציבור רחב. עבור חלק מהמשתתפים, אז זה עשוי להיות מידע מאתגר ומורכב, ואני רוצה רגע להכיר באומץ של כל מי שבחר להגיע לכאן היום, כדי לשמוע את התוכן הזה, להעמיק את הידע שלו ולקבל החלטה מושכלת ואחראית בנוגע לשימוש ולהפחתה. באני מאמין שלנו, אנחנו חושבים שההחלטה לקחת תרופה פסיכיאטרית עם היתרונות והחסרונות שלה, עם הבנה מלאה של היתרונות והחסרונות, היא החלטה אמיצה. וככה גם ההחלטה לרדת מהתרופה, שלפעמים מהווה מסע קשה ומאתגר, ובהחלט החלטה אמיצה. אנחנו מזמינים אתכם לחשוב היום בצורה פתוחה ומורכבת ומרובדת על הדברים שיעלו כאן היום, ונמשיך לחקור את מה שיעלה ויעניין אתכם. אנחנו מקווים שתהנו מהלמידה, בעינינו זה ידע שהוא יקר מפז, ושתוכלו להעביר אותו הלאה לקולגות שלכם, למטופלים שלכם. אנחנו בהחלט גם נשמח שתיקחו חלק בעמותה אם זה מעניין אתכם, בין אם בהתנדבות או בכל דרך אחרת שתבחרו, לצורך את השירותים שלנו או לתרום לנו. אנחנו מתקיימים מתרומות, כרגע חסר לנו עוד קצת תמיכה במחקר, אז אם זה משהו שיכול לעניין מישהו, אז נשמח שתפנו אלינו. ורק תזכורת קטנה, אנחנו ממש ממליצים כל מידע שההרצאה הזאת תעשה, כל משהו שההרצאה הזאת תעשה לכם, ממש מבקשים ומציעים לא להשתמש במידע שיש כאן כייעוץ רפואי אישי, ובטח לא להפסיק את התרופות שלכם בבת אחת. זה הדבר הכי לא כדאי שהכי יכול לגרום לנזק. אז גם כאן אנחנו ממליצים לנהוג בזהירות ובאחריות. כמה הערות טכניות, אז יש כתוביות בעברית זמינות בתחתית המסך, ושזה יעלה ביוטיוב, אז אפשר ללחוץ על העניין של הכתוביות, ויש שם אפשרות לשים כתוביות בעברית אוטומטיות. ההקלטה של האירוע תישלח, ואתם מוזמנים לשאול שאלות דרך ה-Q&A, נבחר כמה בסוף, ואנחנו נצא לדרך. אז now I'm happy to introduce דוקטור מארק הורוביץ, שהוא עמית מחקר קליני, חוקר קליני בפסיכיאטריה בשירות הבריאות הלאומי בלונדון, ב-NHS, הוא מרצה לפסיכופרמקולוגיה בקינגס קולג' בלונדון, חוקר כבוד, הוא גם פסיכיאטר מתמחה, ויש לו תואר דוקטור מהמכון לפסיכיאטריה, פסיכולוגיה ומדעי המוח בקינגס קולג', שם הוא התמחה בביולוגיה של דיכאון ובמנגנוני הפעולה של נוגדי דיכאון. והוא גם המחבר הראשי של הנחיות הפחתת התרופות של מאוסלי, ספר חדש שהוא הוציא ביחד עם דייוויד טיילור. אז מארק הורוביץ, please.
Please tell me that you can see my slides now. Does that look okay?
Yes.
Okay. So I'm going to talk about how to safely stop psychiatric drugs, probably for about 45 or 50 minutes. And I'm going to talk about withdrawal effects from these drugs, how to safely stop them to minimize withdrawal effects from what we know so far. I'm going to spend a lot of time talking about antidepressants and less so about antipsychotics. But a lot of what I'm saying about antidepressants applies to all drugs. It applies to mood stabilizers, to benzodiazepines, to sleeping tablets or Z drugs, to gabapentinoids and stimulants. There is a lot of commonalities. The drugs all act in different ways, but there's a lot of commonalities in the way that the brain gets used to these drugs, causing withdrawal effects, and how to safely stop them. So just be aware that a lot of it's generalizable. So to set the scene for withdrawal and getting off the drugs, you have to understand how our bodies and brains respond when we take psychiatric drugs long-term. So all psychiatric drugs lead to adaptation by the brain and body. So the overriding principle is of homeostasis. We want to stay in the middle. When it's too hot outside, we sweat. When it's too cold outside, we shiver. If a drug does A to the body, then the body will try to make less A happen. So for example, if a drug like an antidepressant raises levels of serotonin in the brain, in the synapse, the brain and body will become less sensitive to serotonin. Whereas if a drug lowers the effect of dopamine, like an antipsychotic, the body will become more sensitive to dopamine in order to balance things out. This adaptation is often referred to as physical dependence, which I'll come back to a bit later, which is different from addiction. It means that our bodies become accustomed to these drugs and we experience withdrawal effects when they stop. Now, when you reduce or stop a drug that you become adapted to or physically dependent on, you'll experience withdrawal effects. And this is because the adaptations to the drug persist for longer than it takes the drug to leave your body. So I'll give an example, because this also plays into how long withdrawal effects can last for. So I'll give you an analogy. If you go to a loud concert, your eardrums become less sensitive to sound in order to protect them. And if you then walk out of a loud concert into a quiet street and talk to your friends, their voices will sound muffled for a couple of minutes. It's actually a sound withdrawal syndrome. What's happening is, when you leave the concert, it takes a second for the sound to go back to normal. The reason why it takes a couple of minutes for your friends' voices to sound normal is because it takes that long for your eardrum to relax to normal levels of sensitivity. In other words, it's the ear's adaptation to the sound that takes the 2 minutes to relax, not the time for the sound to disappear. The same is true for psychiatric drugs. People think that withdrawal effects from the drugs only last a week or two because that's how long the drugs take to leave the system. But that's a misunderstanding of what causes withdrawal effects. It's the time taken for the brain to get accustomed to the drug not being there that explains how long withdrawal effects can last for, like in the sound situation. And in fact, studies have found that psychiatric drugs can cause changes to the brain that can last months or years. So for example, for antidepressants, there are changes in the serotonin system of people who have been exposed to antidepressants that last for up to 4 years after the drugs are stopped. In animal models, we see the same things. Changes to the hormonal system and the serotonin system that last for more than a year in human time after the drugs are stopped. When it comes to antipsychotics, there are changes to the brain that people think there are these changes to the brain because people show these muscular issues, what's called tardive dyskinesia, for months or years or even decades after stopping. And that has been connected to changes to the brain caused by the drugs. And so because these changes to the brain can persist for so long, people can have withdrawal symptoms for long times after stopping. So there is a very wide variety of withdrawal symptoms. These are the ones for antidepressants. There are quite similar ones for benzodiazepines, antipsychotics, each with a bit of variation, but a lot of commonalities. And some of the most common ones, dizziness, trouble sleeping, impaired concentration, fatigue, headache, tremor, a racing heartbeat, nightmares. For antidepressants, for example, there are mood symptoms, depressed mood, irritability, anxiety, and panic attacks. And we know that these are withdrawal symptoms and not just the person's underlying condition returning, because they've been detected in studies of people who've been given antidepressants for reasons other than mental health conditions. So for example, in people who are given antidepressants for the menopause or for pain, or even in healthy volunteers, when they stop their medication, they also demonstrate depressed mood, irritability, anxiety, panic attacks. So we know it's not just a return of these conditions because they didn't have any condition. There are some quite distinctive sensory symptoms, electric shock sensations in the head, often on moving the eyes, or sometimes in the limbs, which seem to represent some kind of irritation to the nervous system. There are gut symptoms, nausea, vomiting, diarrhea, because there's a lot of serotonin receptors in the gut. I think some of those symptoms are starting to be more well known amongst the public and clinicians in the UK. I think there's still a lack of understanding of how severe symptoms can be. And so the two that I wanted to highlight is suicidality. So we know that there's an increase in suicide attempts in the 2 weeks after stopping an antidepressant that's been attributed to withdrawal effects because it's too soon for relapse. In fact, we've done a study where we asked people, did you feel suicidal before you started antidepressants? And 3 out of 10 people said yes. And we asked them, and how many of you were suicidal after you stopped antidepressants? And 6 out of 10 said they felt suicidal. In other words, 30% of people, this is a selected group of people, I'll show you the study a bit later on, had new onset suicidal thoughts only after coming off antidepressants. And we know that some people will take their lives. Akathisia is a Greek word meaning can't keep still. It's recognized by psychiatrists as a side effect of long-term antipsychotic treatment. It's less often recognized as a withdrawal effect from many psychiatric drugs, including antidepressants, benzodiazepines, gabapentinoids, and other antipsychotics. These patients are the worst, sickest people that I encounter. They are often pacing, they're restless, they're agitated, they're terrorized. They have said to me things like they feel their nervous system is on fire and there's a high risk of suicide. And I see this as another sign of significant irritation to their nervous systems. It is often misdiagnosed by clinicians. When people like this turn up to the emergency department, they're often diagnosed with agitated depression, mania, or psychosis. and are often given the wrong treatment as a result of this misdiagnosis. So how common are these symptoms? Is this rare? Is this a small group of very unlucky people, or is this quite common? There is debate about this. So I'll go through it just briefly. There was a systematic review done a few years ago that found that about half of patients who stop antidepressants experience withdrawal effects, and about half of those people say that they're severe. So about 1 in 4 people altogether have severe symptoms. I think what is most interesting about this is the relationship between how long you take these drugs and how much trouble you have coming off them. So this graph shows how long people are on the drugs before they stopped. The top line is, did they have any withdrawal effects on stopping? And this line is, were those effects moderately severe or severe? And what you can see is people who've been on the drugs for a couple of months mostly don't have withdrawal effects. And if they do, they're mostly mild. So most of them are not moderately severe or severe. On the other hand, if you're on the drugs for 3 years or more, most people have withdrawal effects, and about half of those people say it's moderately severe or severe. And that makes a lot of sense because the longer you're on a drug, the more your brain gets accustomed to it, dependent on it, and the more trouble it causes when you stop it. So this makes a lot of sense. Now, one issue that always comes up is, why do they so poor at spotting withdrawal? Why do they not give very good advice on this topic? And I'll tell you where it comes from. A lot of people get very angry at their doctors. They say, my doctor's trying to hurt me. He must be corrupt. He must be on the take from the drug companies. That's not the case. It's really because they're following guidelines, and the guidelines are not very good for the following reason. So most guidelines, my Hebrew is not good enough to look them up in Israel, but most guidelines around the world say discontinuation symptoms or withdrawal symptoms are usually mild and last 1 or 2 weeks, but can last longer in some patients. That's what it used to say in the UK. Now, this description is based on studies done by drug companies in the 1990s, which focused on people who had used antidepressants for 8 to 12 weeks. And it's true that when you stop the drugs after 8 to 12 weeks, mostly they are mild and brief. If you go back to this graph I just showed, when you look at it down here, yes, it's mostly mild and brief. That's true. But in England, most people use the drugs for years. In America, most people use the drugs for 5 to 10 years. In Israel, I'm sure it's very similar to the rest of Europe, so I'm sure that a lot of people use the drugs long term. So to me, the analogy is a car company crashing its car into a wall at 5 kilometers an hour and saying it's safe, and ignoring the fact that people are driving around at 60 or 80 kilometers an hour to say that what is true for people on the drugs for 8 weeks is also true for people on the drugs for many years. Because we know, as you can see from that graph, the longer you're on it, the more trouble people have coming off it. So I think this is very misleading for most patients. And in fact, even the term discontinuation symptoms came from the drug companies, intended to minimize people's worries about these drugs. And they were very active in spreading this message about brief and mild symptoms. They actually had a consensus panel. They were worried about it. They wanted to cut this off at the head, and they put a lot of effort into spreading this. So this is why this happens so often. So it is very common that withdrawal effects from antidepressants and other psychiatric drugs are misdiagnosed as relapse, a return of someone's underlying condition, by clinicians. So we did a survey of 1,300 people. These are people that have had trouble coming off their drugs, so it is a self-selected group. There's 180,000 such people today on different groups getting advice on how to come off, English language groups, I should say. And the main reason that they're all there is this reason. When I went to see my doctor, they told me this wasn't withdrawal, this was my original condition coming back. It's easy to see why that would happen. Withdrawal symptoms can include anxiety, depressed mood, insomnia. When a doctor looks in his textbook, his guidebook, it says Withdrawal symptoms are mild and brief. So when someone walks into their office or their hospital screaming, I've got severe symptoms, they think this can't possibly be withdrawal, which is brief and mild. This must be a mental illness or another condition. And so it's very often that they make this misdiagnosis. And this is why, as I've just mentioned, there are so many people who are on these websites getting advice on how to come off their drugs, who have given up on doctors because they have not found the advice they've been given useful. These are two examples of different websites in America. They get about 1 million hits between them a month, and the story is all the same. Went to my doctor after coming off my drugs after a few weeks. I had terrible symptoms. They told me it couldn't be my drugs. It must be me. It must be a sign that I need my drugs. You may need to go back on it for the rest of your life. But I had symptoms I'd never had before. I had panic attacks. I've never had that before. I had brain zaps. I had headaches. I had dizziness. So I don't trust my doctor on this topic anymore. And I have found that the advice on these websites has been much more useful. And what do these websites say? They say, come off your drugs much more slowly than your doctors suggest. Come off at about 10% of your most recent dose every month. Slow down if you get into trouble, speed up if it's okay. And we'll come back and we'll see whether this advice is more useful than the advice given by most authorities. So how can you distinguish withdrawal effects from relapse? So I've told you that there is overlap. It can be confusing. There's a few clues to help people distinguish these things. So withdrawal effects can be quick in onset. They can normally happen a few days after stopping a drug or reducing it. But again, another confusing point, they can be delayed in onset. They can come on weeks after reducing or stopping, sometimes even months. People find that very hard to understand. I did as well when I first saw that. But there are studies showing that the drugs leave the brain slower than we had thought, sometimes taking weeks. And also there are probably downstream effects that take a while to accumulate. So I have certainly seen many patients presenting with withdrawal effects 3 months after stopping their drugs. There are specific symptoms of withdrawal that can make it easier to distinguish. Things like dizziness, electric shock sensations, make it more obvious that it's a withdrawal effect. But I would go further than that. If somebody went on the drugs because they were very low in mood, they were tired, they were lethargic, and now when they come off the drugs, they're anxious, they're panicked, they can't sleep, it's much more likely that they've developed quite common withdrawal effects than that they've developed a new onset anxiety disorder that just happens to coincide with the moment they stop their drugs. Although a lot of doctors will come to that conclusion and say, look, I think you've developed a new panic disorder in the last few days, which is quite odd. So it's very useful to know what people's baseline symptoms were and compare them to what they experience when they come off their drugs. Another aspect that's more useful in retrospect is if you go back to the drugs soon after you stop, then often withdrawal symptoms go away quite quickly. Although if you wait longer to reinstate, it can be much more unpredictable. And for doctors who are not informed about these withdrawal effects, all sorts of misdiagnoses can happen, not just relapse, but also people get diagnosed with chronic fatigue syndrome, medically unexplained symptoms, neurological disorders, functional neurological disorder, or onset of a new psychiatric disorder. There's many, many different misdiagnoses that we put together in a paper. And the one thing I wanted to highlight is protracted antidepressant withdrawal syndrome. And that's true. Most psychiatric drugs can cause a protracted withdrawal syndrome. Now, the reason why I highlight this is, again, I think there is increasing awareness that psychiatric drugs can cause withdrawal effects. And most people think it's a week or two, it's headache, it's dizziness. Most people think about the movie Trainspotting, Ewan McGregor in a toilet, vomiting up his guts for 3 days, feeling very unwell. They think about short-term acute withdrawal symptoms. But alongside akathisia and suicidality, the third serious consequence of withdrawal are protracted withdrawal syndromes. That is, syndromes that last for months or sometimes years, where people have the symptoms that I've mentioned before, but they persist. So neurological symptoms, trouble with concentration, with balance, with vision, mood symptoms, panic attacks, trouble sleeping, somatic symptoms, pains, shooting pains, tremor, muscle problems. People with these kind of conditions after stopping drugs can end up being bedbound, lose jobs, relationships, financial difficulties. There's very poor recognition by the medical community. And so generally people perceive this, doctors, as relapse or malingering, putting it on, or something psychosomatic in these people's heads. And now there are thousands and thousands of people who cannot get help from the medical system, who are left to fend for themselves or families and friends because they cannot get recognition for these issues from the doctors. I'll just make this point with this table here. We surveyed 1,300 people who had come off antidepressants and were on these different peer support sites. And we asked them, before you started the drugs, what symptoms did you have? And when you stopped the drugs, what did you have? And so, for example, people had impaired concentration, many of them before they started the drugs, when they were unwell. But when they stopped the drugs, almost everybody experienced that. I've mentioned the suicidality before, 3 out of 10. When they stopped at 6 out of 10. Akathisia, I'm very surprised that 1 in 10 people had it before starting, but after stopping it, 2/3 of people had this effect. Muscular problems, I didn't put that in. Dizziness, okay. If I ask an audience, are some of you a bit dizzy? Some of them would say yes, but after stopping the drugs, here we have 9/10 of people with these symptoms. And so you can see that a lot of these issues only happen after people stop the drugs. And in this survey, people had these symptoms last for months or years. You can imagine how big an effect this could have on people's lives. And again, doctors say, well, that doesn't make sense. Withdrawal effects should only last for as long as the drug takes to leave the body. But of course, what is left behind is the residual effects on the brain of these drugs, which can last for a lot longer. So I'm going to now talk, that's sort of the problem. That's what withdrawal symptoms are. That's what you want to avoid. Now I want to talk a bit about how to safely stop these drugs. But first of all, I'll briefly talk about why you might want to stop antidepressants. And again, sorry, I am focusing on antidepressants, but a lot of what I say applies to all sorts of other psychiatric drugs. So let me go back. So there are different reasons why medication may no longer be needed. The stressor that put people on the drugs may have gone away. I should say this, depression is often talked about as a chronic, relapsing, remitting condition. But most people are prescribed an antidepressant in the context of an acute stressor. Divorce, job loss, a physical health problem, a death in the family. And for these people, relapse is unlikely. In fact, framing depression as a relapsing remitting condition like asthma is a little bit of a choice. Because, for example, you could call the flu a relapsing remitting condition that's precipitated by winter viruses, but that would be a strange framing of it. I think the same is true for depression. We generally get depressed when life is terrible. So I think really that life is a relapsing remitting disorder. Sometimes it's horrible, sometimes it's okay. And we feel terrible when it's bad. So I'm not sure that framing depression as a chronic relapsing remitting condition makes a lot of sense for most people. People may have developed alternative coping skills, and many, many people are using antidepressants and other psychiatric drugs for much longer than guidelines recommend. So for example, for antidepressants, most guidelines around the world recommend using antidepressants for 6 to 12 months for anxiety or depression for a single episode. And many, probably around 1/3 to 1/2, don't meet those criteria. I'll talk a bit later about why even that guidance is probably not very strong in its evidence base. But even if we took it at face value, a lot of people are on these drugs for much longer than they should be. There are a whole lot of side effects, or what are called side effects, harms from these drugs. We know from antidepressants, more than half of people will experience sexual side effects, inability to enjoy an orgasm, trouble with erections, We also know that more than half people experience emotional numbing. The emotional numbing might be useful in the short term for people, but it's the main reason people come to my clinic in London, where I help people to stop these drugs, because they feel it means they don't know who they are anymore. They don't know what they enjoy. They're not sure what they think of their partners, their loved ones. Fatigue, impaired memory, impaired concentration are all common. Insomnia. And there's an increasing literature about worsening anxiety and depression caused by long-term antidepressants, what's called tardive dysphoria. And although there wasn't much weight gain seen in the short-term trials for these drugs, in longer-term trials, weight gain is a significant issue with long-term use of antidepressants. An important barrier to coming off these drugs from research is a lot of people have been led to believe that depression is caused by a chemical imbalance in their brain. If we ask the public in the West, about 90% of people will say that's what they believe depression is caused by, amongst other things, but they put chemical imbalance up there. Studies have shown that people who believe that are much less likely to want to stop their drugs. It makes sense. If you believe you've got a deficiency of serotonin, you're on a drug that increases serotonin, why would you stop it? The only issue with that story is, of course, there's no evidence that finds that depression is caused by low serotonin. It was originally a hypothesis. There's been 6 decades of research, and that hasn't shown any difference between depressed people and healthy volunteers. And of course, given that 70% of people will experience a major depressive disorder in their lives, it's hard to believe that 70% of people have something abnormal about their brain. That would be quite strange. There are other explanations for how antidepressants might work: stress hormones, inflammation, growth of new neurons. Talk about them a bit more. But most of that evidence comes from animal studies. It hasn't been shown in humans. It may not be a good sign that drugs increase the growth of new neurons, new brain cells, because lots of things that damage the brain also cause the growth of new brain cells. So things like stroke or blunt trauma or chemical damage. So for example, cutting your skin causes the growth of new skin cells. Doesn't mean that cutting your skin is good for skin. So there's been a lot of hype around that explanation. That's what I did my PhD on, but I'm a bit suspect that that's necessarily a good thing. And so I would argue that the clearest way that antidepressants work is by numbing people's emotions. In surveys, a half to 3/4 of people say that's how they feel on antidepressants. You can see how that would be a big relief if you had terrible, negative, unpleasant symptoms, and how it might cause trouble in the long term. So I think that if people understood how the drugs work, they can make more informed decisions about what they'd like to do. There are no long-term studies comparing placebo and antidepressants in terms of people's physical health. So all we have are studies where they examine people who are on the drugs and not on the drugs. And what they find in these studies is people that are on antidepressants in the long term are more likely to have strokes, be obese, have falls, fracture their bones as they get older, have cardiovascular disease, have weak bones, osteoporosis, and to die early. And there's a debate about how much of that is due to depression and anxiety and how much due to the drugs. But at least some of those things cannot be explained by depression or anxiety and must be due to the drugs in part. People may wish to stop, wish to pursue alternative strategies. Women who wish to become pregnant may wish to avoid the small but significant increase in issues that come whilst taking antidepressants while being pregnant. For older people, there are different reasons about reducing polypharmacy and pill burden. It's just a quick overview of reasons why. So now I want to spend some time talking about what is the best way to stop antidepressants. And again, what I'm saying applies to a lot of other drugs. So this is guidance put out by the Royal College of Physicians in the UK about how to stop antidepressants, published a few years ago, and it recommends a few people can mute their microphone.
אתם הולכים גם לחדר אוכל? אני אשאר פה.
Okay. Oh, you've unmuted. I get it. Okay. So these guidelines recommend tapering off antidepressants for anybody that's been on them for more than a few weeks, over months or years. They suggest going down to very small doses, maybe less than 1 milligram before stopping, much smaller than commonly available tablets or capsules. And they recommend going down in smaller and smaller size reductions. And they say the rate should be adjusted to the individual's ability to tolerate the process. So some of those things may sound a bit unfamiliar to some people, and I'll talk through where do they come from. So we published a paper now 5 years ago in the Lancet Psychiatry, looking at the way that antidepressants, and as you'll see, all other psychiatric drugs affect the brain. And this is neuroimaging of people on citalopram, a very common antidepressant. And what it shows is the dose on the x-axis and the effect on the brain on the y-axis. It happens to be effect on the serotonin transporter, the main target of the drug, but you can think of it as effect on the brain. And the main point is it's not a straight line. Doubling the dose doesn't double the effect. So going from 20 milligrams to 40 milligrams doesn't double the effect on the brain. In fact, there's not a very big difference at all. And a tiny dose, so the smallest tablet in Israel will be 20 milligrams. Even a tiny dose like 2 milligrams, I don't know if you can see that behind the translation, but down here there's 2 milligrams. It actually has half the effect of 60 milligrams, much, much bigger than you would expect. And this is because of a pharmacological law called the law of mass action. It basically says this: when there's not much drug in the brain, all the receptors for the drug are open for business. And every milligram of drug has a big effect on the brain, a bit like the game of musical chairs. Near the beginning of the game, all the chairs are there, it's easy to win. As there's more and more drug in the brain, more and more receptors are filled up, and every extra milligram of drug has less and less effect, like at the end of the game of musical chairs. So you get this law of diminishing returns. It flattens out. Now, that allows us to understand what happens when people stop their drugs. So actually, I missed a slide out. Most guidelines recommend that people stop their antidepressants by halving their dose for a couple of weeks, then halving it again for a couple of weeks, and then stopping it. That's what the guidelines said for many years in the UK. They still say that in America. They still say that in Europe. We've interviewed patients. We know that's what most doctors recommend. This graph, can I move this? Oh, yeah, I can. This graph explains what happens when people follow the guidelines on this topic. You're at 20 milligrams of citalopram. You go to a half at 10 milligrams. It causes a reduction in effect on the brain. Some people find that very unpleasant. Some people can find that okay. Then you go from 10 to 5, another half. That's a bigger change. A lot of people find that quite unpleasant. But when people go from 5 milligrams to 0 milligrams, it's a much bigger change. To me, it's like jumping off a cliff. If you imagine that this curve is like a path, you're walking down a very shallow path, like a country walk. It turns into a steep hill, and then it turns into a steep cliff. And people fall off this cliff all the time. And because most clinicians are not aware of this relationship, what they see is a patient who ends up in huge trouble, panicked, not being able to sleep, and they think, well, they must need the drug. They must have relapsed, because they don't understand how big this final reduction causes for patients. So what would make more sense is not to go down by equal amounts of dose, but to go down by equal amounts of effect on the brain. And so I've drawn 4 horizontal lines at 20 percentage point differences, and that corresponds to smaller and smaller reductions of the drug down to very small final doses, 0.8 milligrams. So when you go from 0.8 to 0, the reduction in effect on the brain is not bigger than these previous steps. And because this curve is called a hyperbola, if you remember from high school mathematics, this reduction scheme has been called hyperbolic tapering. I'll say this. Sometimes it's simpler to explain to people in terms of a proportion of their dose. So for example, reducing by 50%, let's say every month, would be like 20, 10, 5, 2.5, 1.25, 0.6. That produces roughly even amounts of change and effect on the brain. Not exactly, but close enough. And some people will find these jumps too big. And so you can insert intermediate steps, 25% reductions per month. And some people will only need 10%, will only be able to tolerate 10% dose reductions per month, so that the doses get smaller and smaller. And in fact, so when I saw this graph and understood that what people recommended on these websites, on peer support sites to help people stop the drugs, when I realized that people had worked out through trial and error exactly what the brain scans of these drugs showed, that made me spit out my soup that night, because thousands of people had sat around, trial and error, small changes to their drugs, and they had exactly traced out this curve from brain imaging of the drugs. I think that cannot be a coincidence. And just to make the point, sorry, I should use this is Prozac, this is Effexor, this is Paxil, this is Zoloft. They all have the same relationship. And I'll show you later on, every antipsychotic, every mood stabilizer, every stimulant, every benzodiazepine, every Z drug, it's the same shape, because it's a general law of pharmacology about the way these drugs work. And so everything I've said for antidepressants also applies to other psychiatric drugs. So let me take it a bit further. So that's the theoretical basis. Does this work in real life? I'll just briefly talk about this. So there have been no randomized controlled trials yet of this way of tapering. There is 2 underway, one on antidepressants in Queensland and one on antipsychotics in France, that will report in a couple of years. What there is at the moment is about 4 studies, quite large studies of 1,000 people each approximately. And each of these people are people that tried to come off in the regular way, halving again, and couldn't do it. And they were given access to doses of medication that made it easy to do a hyperbolic taper. So they were given 20, this is a citalopram, 20, 19.5, 19, 18.5, all the way down to 0.5 milligrams. And this is the shape of their reduction schedule. In other words, exactly like a hyperbola. It went down more quickly at the beginning and very slowly at the end, so that people were reducing for the last milligram very, very carefully. And basically what they found was most people who couldn't get off their drugs in the traditional way could come off their drugs this way. Not everyone, 3/4. Some people probably needed to go slower, but that's what they achieved. And when these people were asked, how terrible were your withdrawal symptoms with the traditional way? This is not at all terrible. This is very severe withdrawal symptoms. So most people said, I had very severe symptoms coming off in the traditional way. And when they came off in this much slower way, most people said they had 2 out of 7 symptoms. In other words, mild symptoms. And we're looking forward to seeing what the randomized controlled trial will show for this study, for this approach. To return to the Royal College of Psychiatrists guidance, they say you need to individualize the rates to the rate that can be tolerated by a patient. So there's a little bit of trial and error because everyone's a bit different. I'll talk in a bit about what are the risk factors for having trouble, but it's a bit hard to tell. So often you need to do a bit of a test reduction and adjust things to match the individual. Some people have a lot of trouble, some people less trouble, but you should be guided by what the person experiences. And if people get into trouble, the best thing to do is normally to halt the reduction or increase the dose a bit, or sometimes a lot, pause, wait to stabilize, and then go much more slowly after that. And some people can only go at about 10% of their most recent dose per month, like I mentioned. And so now the Royal College of Psychiatrists actually has the same guidance as some of these websites that I talked about before. And here are some examples that the Royal College gives. This is what I would think of as quite a fast reduction for someone that had used their medication only for a few months, let's say. This is the halving the dose several times. And you can see at the end, people need to use a liquid to make these very small reductions. And here's an example of a drug that's harder to come off, paroxetine. And here's an example of what it would look like to come down by about 10% of your dose every month. so that the reductions get smaller and smaller. So you start off by coming down at, say, 4 milligrams, that's 10% of 40. By the time you're at around 20 milligrams, you're only coming down by 2 milligrams a month. And by the end, you're coming down by tiny fractions of a milligram. And there's actually 30 further steps here. And this process can take people 2, 3, or 4 years. And certainly in my clinic, people can take 2, 3, 4 years to come off these sort of drugs, going very carefully at the end. So this is not unusual. So people often ask the question at this point, how do you make up these small doses? You know, tablets only come as 20 milligrams or 10 milligrams. How can you possibly make up 0.8 milligrams? There's a few different options. When you're at higher doses, tablet cutters can be helpful, halving or sometimes quartering round tablets. Liquid drugs are very useful. So I've just found out from Dr. Pesach that only a very small number of drugs are available as liquids in Israel, including fluoxetine for antidepressants and a couple of antipsychotics. Some specialist pharmacies can make up smaller dose capsules, tablets or liquids. They often cost a bit more money. They're specialist pharmacies. A couple of points here. Some doctors try to help patients come off slowly by skipping doses. They think, well, having a smallish tablet every second day is a bit helpful. Unfortunately, it's mostly not. The reason why is these drugs are often eliminated from the body over about a day, the half-life. And so if you skip them every second day, you get wildly up and down levels in the blood, and that can cause withdrawal symptoms for many people. So skipping doses every second day is not a very good approach unless you have a drug that lasts a long time in the blood, like fluoxetine. That's the one exception here. The last point is some doctors say, well, let's switch you across from a short-acting drug to fluoxetine, a long-acting drug. There's a bit of merit in that, except people believe that fluoxetine can just be stopped and there's no trouble coming off it, but that's not true. Many people coming off fluoxetine will have trouble, about half of people. It's not that dissimilar from other drugs. And the manufacturer did a study where it fiddled it a little bit by looking at this drug only for a week, and it takes this drug about 6 weeks to produce withdrawal effects. So they somewhat fiddled the data and made it look like it was easy to stop. So in general, when I taper people off their drugs, I stay at the drug that they're on rather than switching to another drug, because that tends to cause more trouble. You're stopping one drug, starting another drug, now you're tapering the second drug. In general, it's easy to start on the drug that people are on and come off that. There are other what are called off-label options. So off-label means it hasn't been approved by the manufacturer of the drug, but it's perfectly legal. Anybody can do whatever they like with the drug. So one example, and this is from a government website in England, it explains that you can crush tablets of antidepressants in water, mix them up, and give it and take it that way. This guidance is written for people that cannot swallow tablets. There's also guidance for mothers to give their children smaller doses. So it's perfectly possible to crush up tablets, mix it with water, and use that to make up a liquid that then gives you a lot of control over how much you dispense with a syringe. We wrote this textbook called the Maudsley Prescribing Guidelines. It gives guidance on how to stop all antidepressants, benzodiazepines, Z drugs, and gabapentinoids. We wrote it for psychiatrists, for GPs, for pharmacists, for nurses, and also for interested members of the public. It explains withdrawal effects for each drug, how to distinguish them from relapse, how to work out what rate to go at for each patient, how to adjust it, and also what different formulations of medications are available in different regions, including Europe, but not specific to Israel. I'll just show you a few things that are useful. This is, for example, a guide on how to work out who is at risk for withdrawal and who is not. So very quickly, it's a sort of a point scoring system. Depending on how long you've been on the drug, gives you different points, short-term low, long-term high. Certain drugs are higher risk than others. So for example, drugs like Cymbalta, duloxetine, venlafaxine, Effexor, paroxetine are much higher risk than other drugs. although almost all antidepressants can risk withdrawal effects. So, for example, even fluoxetine is still a moderate risk drug. Dose plays some role, and then your past experience also explains what you're probably likely to have in the future. Put that together, you can work out who's low risk, who's high risk, and that can give you some direction in what rate to go at. We have different examples. This is a faster rate for a low risk person coming off citalopram. We have different doses, when to use tablets, when to use half tablets, when to use liquid, how to use liquids. If people have trouble, this is a slower version. People that have a moderate risk, and we have even slower versions. I'll just go very briefly through some practical examples before I talk very briefly about antipsychotics and other drugs. So I'll give you an example. Venlafaxine is a very difficult drug to stop, Effexor, one of the hardest drugs to stop. There are different ways to reduce it, and one of them is to use the fact that many of these drugs come as beads in capsules. And so, for example, this is a picture of what it looks like. For example, if you open up these capsules and count the beads, you can reduce the amount of drug you take every month. First of all, I should say, the manufacturer of the drug has done tests on this to see whether these beads are stable outside the capsules, and the answer is that they are. And they're stable if you mix them with certain different juices and not with other juices. They've done this sort of work. It's not an approved use. The manufacturer doesn't recommend this, but it is possible. One important point from the FDA is you shouldn't swallow the beads directly because it can irritate your throat. You should put them back in another capsule, either the original one, and swallow it that way so it doesn't hurt your throat. So I'll give you an example of what it looks like. If there are 300 beads in a 75 milligram capsule of Effexor or venlafaxine, you can reduce your dose by 10% by taking out 30 beads in the first month, see how things go. If that rate is okay, you could take out a further 10% of beads, which would be 27 beads. And you can go on like that. You can also weigh the beads rather than count them. You could use a jeweler's scale from Amazon. They aren't as expensive as you might expect. Another option is you could break down that process into making much smaller reductions each day. So rather than going down 30 beads a month, you could do 30 beads by going down in a month, by going down 1 bead each day. And that causes a bit less destabilization, what's called microtapering. The analogy there would be if you had to get down flights of stairs, what would hurt your knees more? Jumping down 30 stairs in one go, waiting 30 days to recover and then doing it again, or going down one stair every day. You know, in general, going down a little bit every day would be better for your knees, the same for your brain. Alternatives are you can compound a liquid and use the liquid, which you need to take twice a day to make small reductions. You can also pulverize these beads to make a solution out of them, which makes them lose their long-acting properties, and therefore you need to take the drug twice a day. I won't go into this too much. This is an example more relevant to England with a liquid. You could get a liquid from a compounding pharmacy in Israel. You could mix it with water, use syringes and make small reductions over time. There are other options like tablets that dissolve in water. So for example, mirtazapine sometimes can dissolve in water. You can crush it up, mix it with water, and use a syringe to measure out small reductions. I'll do a special note about duloxetine or Cymbalta. It cannot be pulverized. It cannot be made into a liquid because the beads are important for getting it through the stomach and protecting it from stomach acid. So the only way that exists at the moment to come off duloxetine is to count or weigh beads. I have heard of a manufacturer in America who's making stomach-resistant capsules, which may make it possible to use powder inside. And a quick note that crushing and suspending tablets with water or with syrup is easier with instant-release drugs and extended-release drugs. I'll just quickly talk about antipsychotics and other drugs, so I don't go on too long here. Antipsychotics also cause withdrawal symptoms. It depends on the receptors that the drug affects. The most common symptom is insomnia. Other things like movement disorders, dizziness, anxiety, depressed mood. Withdrawal symptoms from antipsychotics probably include psychotic symptoms. I'll talk about that in a second. Some drugs have more severe symptoms, like clozapine is notorious for having very severe symptoms coming off it. but all antipsychotics can have some effect. So the fact that this can include psychotic symptoms is probably the most important point, because when people stop antipsychotics, you know, like a lot of other psychiatrists, I've been in the emergency department, someone comes in, they're psychotic, very psychotic, they've just stopped their drugs a few days or weeks ago, and everybody jumps to the conclusion they must need their drugs to prevent relapse. And what's happened is they've stopped their drugs and they've relapsed. But there is some evidence that that may not be the entire story. So some people are given antipsychotics or drugs that are very similar, that is, drugs that block dopamine, for reasons other than mental health problems. So two main ones are metoclopramide, which is very similar to an antipsychotic, is given for nausea. And young mothers that have trouble with lactation are sometimes given domperidone, which is a dopamine blocking agent, very similar to antipsychotics. So there are case studies of people that were given these drugs for these reasons, and they use it for several months or sometimes years. And when they stop the drugs, they experience psychotic symptoms on stopping. They've never had any psychotic disorders before. On stopping, they experience hallucinations, auditory, they experience delusions, that people are after them, that they're dying inside, that their friends and family have been replaced by aliens. In other words, the same delusions and hallucinations you see in schizophrenia. One case study, a female lawyer, very high functioning, no mental health problems, who started on a drug for lactation, an antipsychotic-like drug. She used it for 10 months. When she stopped it, she developed 10 months of psychotic symptoms. In many of these cases, people have to be restarted on their antipsychotics and tapered off more slowly. And in all of these cases, people have attributed these symptoms to the development of increased sensitivity of their dopamine receptors. So right at the beginning, I said, take a drug long-term that blocks dopamine, your receptors will become more sensitive to it. Now, when you stop the drug, you've got very sensitive receptors that can react very strongly to normal levels of dopamine. And that's probably what causes these withdrawal psychoses. And so this may be one reason why people who come off antipsychotics experience psychotic symptoms, not just because they've got an underlying condition, but because of the process of stopping it. This is another line of evidence that may be true. This is a study that looked at people stopping antipsychotics and also how quickly they stopped antipsychotics and whether they experienced a psychotic relapse afterwards. So in 14 studies where people stopped abruptly in one day, almost 80% of people had a relapse of their psychosis. As they went slower and slower, and I would still say this is very fast in my view, but when they got to people who stopped over months, the rate of relapse was much lower, 30%, not 80%. Now, this means it must be a withdrawal effect because all of these people have psychotic, these are all people with schizophrenia, with psychotic conditions. The only difference between these studies is how slowly the drugs were stopped. If that changes the rate of relapse, it cannot be the underlying disorder that's responsible for it because they all have the same disorder. It must be something to do with the rate at which they're being stopped, and that's likely to be because of the withdrawal effects. Quicker stopping, more withdrawal, less stopping, less quick stopping, less withdrawal. And then these pictures are now familiar to you. Everything I said before for antidepressants is also true for antipsychotics. Very tiny doses of haloperidol, 1 milligram is the smallest tablet, has a very large effect on the brain. Almost 2/3 the effect of 10 milligrams. Risperidone, another common antipsychotic, the smallest tablets, might be actually it's 0.5 milligrams, but even 1 milligram of the drug has almost half the effect of 8 milligrams. This isn't just, this is again, imaging of the brain, but it's also true of the effects clinically. This is dose of the antipsychotic versus effect on psychotic symptoms, the same pattern. At lower doses, the effects go up very quickly. At higher doses, they flatten out. So it matches the brain relationship. And again, the same principles. If you go down from 4 milligrams of a drug, 4, 3, 2, 1, 0, it makes a lot of sense intuitively, but in terms of effect on the brain, it doesn't make sense at all. The last reduction from 1 to 0 causes a much bigger change in effect on the brain than the first reduction. So in fact, going from 0.25 milligrams of haloperidol a quarter the smallest tablet, actually has a bigger change in effect on the brain than going from 10 milligrams to 2 milligrams. So it's a very steep curve. And again, it makes more sense to go down in this hyperbolic way by smaller and smaller amounts down to very small final doses. So here is it in numbers. These are all equal steps in terms of effect on the brain. You need to go down to these tiny, tiny doses, much smaller than the smallest tablet, and you generally need to use a liquid for that. I understand in Israel, for example, haloperidol comes as a liquid. Here's some examples for very common antipsychotics. These are all equal sized steps. And you can see for all of them, the final step before stopping is a tiny, tiny fraction of the smallest tablet. Amisulpride, I think the smallest tablet is 50. Quetiapine, the smallest tablet is 25. Clozapine, 25. You can see these are very small doses compared to the smallest tablet. Very briefly, putting together a whole lot of studies, it looks like coming off at about 5 to 10% per month of people's last dose makes most sense. Exactly matching what people have achieved through trial and error. And again, if people get into trouble, so I did this a lot. I worked on a trial for 3 years, helping people to come off antipsychotics. I had the same approach I mentioned for antidepressants. If people had trouble sleeping, worse with psychotic symptoms, I would pause or go back a step or two, wait for them to stabilize and go down more slowly. And many people who had trouble going down more quickly didn't have trouble going down slowly. So, for example, when I reduced one guy's medication from 5 milligrams to 2.5 milligrams, he had a lot of trouble with psychotic symptoms. When I went over 6 months down in much smaller reductions, he didn't have any trouble at all with withdrawals, with psychotic symptoms. So going in the slower way has a bigger effect, and we'll publish some analyses about this next year. Again, to repeat myself, everything I've said for antidepressants is also true for other drugs. This is the NICE guidelines, the government guidelines in the UK, again saying reduce by proportionate amounts of the existing dose so that reductions become smaller and smaller. That's for benzodiazepines, Z drugs, antidepressants, opioids. And again, the same relationship applies for diazepam or Valium. The last milligram is harder to come off than the first 25 milligrams from 100 milligrams, has a very big effect. Here are some examples of reduction schedules from the textbook for Valium. You see how slowly they go. The same is true for pregabalin or Lyrica or gabapentin, known as Neurontin. Again, very, very small doses have very large effects, so you need to go down very carefully at the end, often using liquids. And I haven't shown the same is true for all other psychiatric drugs. I think I have talked for long enough, so I'm happy to. I think Dr. Lichtenstein is going to talk to me for a bit, and then I'm happy to take any questions in English.
Okay, thank you very much, Mark. So I will introduce Pesach for having the conversation. So in Hebrew, אז פרופסור פסח ליכטנברג, הוא פסיכיאטר ופרופסור באוניברסיטה העברית בירושלים, מייסד סוטריה ישראל והקים את הבתים המאזנים הראשונים בארץ, והוא הוא משמש כמנהל היחידה לאשפוז ברוח סוטריה בבית החולים בכפר שאול, ועמד בעבר בראש המחלקה לפסיכיאטריה בפקולטה לרפואה של האוניברסיטה העברית. הוא מחבר הספר Psychopharmacology, Reconsidered, a concise guide exploring the limits of diagnosis and treatment. אז פרופסור פסח ליכטנברג, תודה שאתה פה, בבקשה.
תודה, גולן. Mark, thank you very much for a very fascinating, illuminating lecture, much needed in this part of the world where so little is known about deep prescribing. Well, we don't even have a Hebrew word for deep prescribing, and if somebody can suggest now in the chat how that should be translated into Hebrew, well, feel free to coin a term. I thought about the Chadal Rishum or Al Rishum, but be creative. I'm suggesting to to the people here to think about a way to translate this into Hebrew. Now, Mark, my first question is on a more personal note. Come on, you're a shrink. You were trained to write prescriptions. You're supposed to be giving out these medications. How did you get into this deprescribing stuff?
Right. Look, I guess it's through personal experience. You know, I grew up in Australia. I went to medical school. Did my psychiatry training, started it there. Did some in London. You know, I followed all the passed all the exams. I followed all the instructions that I was told. I actually did a PhD in how antidepressants work at King's College London in London. When I looked at the biology of depression and how the drugs work. And basically at the end of my PhD, I read a paper about withdrawal effects from antidepressants. And I found that very startling because I'd never heard of it before. And it made me worried because I'd been on an antidepressant at that point for 13 years. So I guess on the other side of the desk of being a doctor, I'm sure the work of Woody Allen will be known to people there. That's a pretty good representation of my upbringing. So I was a neurotic young man, neurotic older man, and you know, at the age of 21, when it was given an antidepressant, actually Lexapro or escitalopram by a GP, and I'd been on it for 13 years when I read that paper. And I actually had another number of health problems while I was on the drugs, problems with fatigue and memory and concentration issues. And that paper was basically a trigger for me to try to come off the drug. And what I did was, I'm a very nerdy PhD student. I read all the papers about how to come off these drugs written by my professors and the leaders in the field. And they all said coming off these drugs causes brief and mild symptoms, and you can come off by halving the drug for 2 weeks and halving it again for another 2 weeks. I thought that's very reassuring. And then I went and read, I typed into Google the same thing because I'm a millennial, albeit a geriatric millennial. And I had a very different story come up. People had severe symptoms coming off, took them years. Some faced near-death experiences. I thought that's not very helpful. I wasn't really sure who to follow. And so I sort of split the difference, and I came off over a few months, much slower than guidelines recommended, but not as slow as I read about. And basically, my life imploded. I started having trouble sleeping. I would wake up in full-blown terror in the mornings, like I was being chased by a wild animal, sweaty palms, beating chest. And I'd be in that state of panic or terror for about 10 hours of the day. I'd get a bit of relief in the evenings when I could eat. I'd be dizzy. Things around me appeared unreal. I took up running because it gave me some relief, and I ran until my feet bled. I must have listened to about 2,000 mindfulness meditation tapes. It went on day after day, then week after week. And I thought, I don't think I can keep living like this. I should say, you know, the symptoms I had before I went on the drugs, I was an existentially confused young man. I would have given that a 4 out of 10 in terms of intensity. When I came off the drugs, it was 10 out of 10. So there was no point in my mind that I think it was the same thing. And eventually I went back on the drugs. And I realized at that point, I wasn't on the drugs because they were helpful to me. I was on them because I couldn't get off them. I was essentially trapped on the drugs. And basically that, I was so scared by it, I went back on the drugs for a couple of years. Later on, I've now in the process of coming off them again. And this time I followed the experts, which were the people whose accounts I read online. They'd worked out how to come off the drugs. They said go a lot slower. And in following their guidelines, I was able to come off the drugs. And I just thought, this is utterly ridiculous. I've got a PhD from then the top institution in the world on psychiatry. You know, I'm training to be a psychiatrist. How come I'm learning how to come off these drugs from a retired software engineer, you know, on a peer support website? And so from then on, I've basically suspended my career since then, and I've just spent my time trying to tell other doctors about how to come off these drugs safely, and I've written papers, and that's why I've been a very bad shrink.
Yes, yes. I wish that for more of us. Very interesting. But now, most of the lecture is about antidepressants and naturally about all of the severe problems with getting off of it. You didn't cover what you've written about, summarized very cogently in some of your papers about how, to begin with, the effectiveness of antidepressant medication is not great, to put it mildly. It's often shown not to be more than placebo, not significantly more in any meaningful clinical sense when you look at the whole, when you compare it to placebo, and placebos have a lot of advantages in that way. And also, I used to think that, okay, but for the more severely depressed, you still need the medication. Some of the more recent meta-analyses have cast doubt on that. So I'd like to ask you, shrink to shrink, are there times when you do, nevertheless, find yourself prescribing an antidepressant medication for depression?
Look, I think it's a difficult question. I do see it as being, it is hard to make the case for it. You know, I think there's a few things to weigh up. Number one, the effectiveness of the drug. Exactly, it's minimally effective. That's also true for severe depression. I think people, that often escapes people. Even for severe depression, no study has ever shown a clinically important difference from placebo. Statistically different, yes. Clinically important, no. Which is a bit like showing, for example, a weight loss drug is better than placebo, but it only produces 50 grams of weight loss. In other words, it's an effect, but it's very small. And that's true even for severe depression. So there's the effectiveness, that's the one issue. The second issue is the side effects, the adverse effects. I talked about already a few of them in my lecture. There's now, I didn't mention it, there's now research coming out that sometimes the sexual problems that people have on antidepressants don't go away when you stop the drugs. Now, a paper just, people can't get erections. They describe that their genitals feels like their elbow, and it can last for years and decades. There's a debate about, is it permanent? I hope not, but I don't know. How common is it? One paper from Israel said it was 1 in 200. Paper came out a few weeks ago saying it's 1 in 7. Now, if it's 1 in 7, that's a very big deal. I don't know if that's true or not, but that's a very concerning effect of the drugs. Protracted withdrawal, I've talked about. How common is that? I don't know. We're going to publish a paper showing that 1 in 7 people that we selected from the NHS has it when they stop their drugs. That, to me, is a very large amount of people. It may be an overestimation. That's a very big issue for people. So that's the adverse effects, trouble stopping it. And then number 3 is the alternatives. In England, we have a government department that puts out guidelines for depression. In some countries like Australia and America, the guidelines are put out by the colleges of psychiatry, and they're full of conflicts of interest. So in the Australian and American guidelines, almost every person on those guidelines will take money from drug companies, and almost every one of those drugs that those drug companies make are in the guidelines. I'm not saying there's a connection, but I'm just making an observation. In the UK, they don't permit that. The guidelines in the UK are very different to in America and in Australia. And they say that there are 21 treatments that are equally effective and cost-effective for depression. For severe depression, they say there's 11 treatments. And of those 11 treatments, 2 involve antidepressants and 9 don't. This is not mild depression. This is severe depression. This means in hospital. They find that different forms of therapy, exercise, mindfulness are as effective as antidepressants. In fact, the most cost-effective treatment for severe depression is problem-solving therapy, which I think really brings it back to what causes people's depression. Now, that's why I think, seeing it as an illness like asthma is misleading. It's often the context of people's lives, which is why problem-solving makes sense. you know, to be a little bit glib, to recycle a line, you know, for talking about suicidal people, you know, the real pointy end of things, I think, you know, the only way to make people less suicidal is to make their lives more worthwhile. I don't think that there's a drug that can change that. And so that very much informs my approach, those three things: the small advantages, the significant harms, the numerous alternatives. I think is what informs my practice.
Oh, I'll take that as a no. As to whether you actually ever prescribe medication. And yes, these are frightening things. I'm just, what you're saying is, I mean, you have a young man coming, and just imagine telling him that you have this antidepressant, it might help, and there's only a very small chance that you will never again enjoy sex. That would not be good marketing for the drug. And I've had one patient who 12 years after stopping complained bitterly about that. And at the time, I'd not read about this possibility. So I thought, well, he's probably still depressed, but no, he wasn't. Okay. Nevertheless, despite what you showed, you spoke about psychosis and so-called antipsychotics, the dopamine receptor blockers. And I'd like to try to make the case anyway that antipsychotics are certainly more clearly necessary. I mean, depression is considered something which occasionally happens and then it passes, even without medication. That's what we all know. And so you say, get off it quickly. That makes sense. Maybe don't start it because it doesn't help and all the problems. Not going to go over that. Most people, not all, but it would seem that most people who have a psychotic disorder, it's a struggle which will accompany them to some extent for years or possibly for all of their life. And deprescribing in psychosis is more, in my experience, it's let's go down very slowly, very gradually. And how far can we go? I don't know, but at some point you'll have something which appears indeed to be a return of the psychosis this time. Okay, we found how far we can go. And my colleague Aviv Segev has written about this approach. I think it's something which, by common sense, we've gotten to. And so I like to put in, relatively speaking, a plug for antipsychotics compared to antidepressants.
So I'll say a couple of things in response to that. So I agree with you broadly. I think antipsychotics are more useful for psychotic states than antidepressants are for depression. But I think I'll just zoom out for 1 second, which is, I touched on it in my talk, but I'll make it a bit more explicit now. So I think that the way that I understand drugs has been very informed by Joanna Moncrief's work that I'm sure Pesach and David are familiar with, but I'll say it for the rest of the listeners. There's two different ways of understanding how psychiatric drugs work. One is what would be called the disease-centered model, that the drug acts on the underlying cause of a disease and therefore makes the symptoms better. And the archetypal example would be antibiotics for a lung infection. You've got a cough, you've got a fever, and if you give an antibiotic, it kills the bacteria that causes the infection, so you feel better. And psychiatric drugs are often presented as acting in that way. And even the names sound the same as antibiotics. Antipsychotics reverse whatever's going on in psychosis, and antidepressants in depression. And with depression, the idea that it's caused by low serotonin, the drugs increase serotonin, it fits that kind of narrative. The same is put forward for dopamine blockers, antipsychotics in psychosis. There's more evidence for dopamine being effective in psychosis, but it's not as simple as people have high dopamine and therefore they have psychosis. So I think there's holes in that story. The other way of looking at how psychiatric drugs work is what's called the drug-centered model, which is these are all drugs, they're molecules that cross the blood-brain barrier. They affect the way we think and feel. An example of that is alcohol. let's take it in the example of social anxiety. If you're anxious around people, drinking alcohol can make you feel less anxious and more relaxed. Nobody thinks that alcohol is acting on the underlying cause of social anxiety. We all understand that alcohol is being superimposed on top of underlying symptoms. And when it wears off, the effect will wear off. And no one thinks that social anxiety is caused by a deficiency of alcohol. And so I think that frame for understanding how psychiatric drugs works is useful. So antidepressants, I think that's where numbing comes in. I think that's how they work. And antipsychotics, before they were branded antipsychotics, used to be called major tranquilizers. That's how they were referred to by people who first discovered them. They were used in anesthetics, and they were transferred to psychiatry. And if you take them, taken one antipsychotic once to try it, you think and feel less. That's how I would put it. A colleague of mine took a dose of antipsychotic and said the whole world turned grey for 24 hours. And I think, so I think of them as major tranquilizers. Now, is a major tranquilizer useful? I think it is useful. If someone is completely psychotic, dangerous, I think that they need to be tranquilized in some way, and a chemical that does that is useful. And some people may have net benefit for using a major tranquilizer in the longer term. I think it also have lots of consequences I didn't get into. Functional consequences, ability to think, organize, and function. There are studies showing that people that reduce antipsychotics can have better functional outcomes. So I support your approach of reducing to the smallest possible dose. I often think people don't reduce slowly enough, and they trigger withdrawal symptoms. I didn't go into that in my talk, but there's a few cases that I saw when I came down too quickly. People had psychotic symptoms that would have had them admitted, but I had the luxury in my study of being very careful, going back, waiting for them to stabilize and going down more slowly. I also think that some people have changes in their condition that varies over time. So that some people have terrible times in their 20s and 30s, and they end up stabilizing as they get older. So I'm not sure, it's often seen as a chronic lifelong condition. It may be for some people, but I think for some people, others, things can resolve. I won't use up too much more time, but I saw a couple of cases that I was able to take off their drugs over 2 years, who were really able to articulate how trauma as a young person had turned into voices, that they had sort of made sense of in their slightly more adult, mature, reflective form, that had become less distressing. So what had shocked them as a teenager and terrified them, made them act very bizarrely, was not nearly as alarming to them in their late 30s and early 40s. So I agree with you broadly. Some people may need these drugs long-term, may be beneficial. I do think things can change for people. I think some people can find other ways of managing symptoms or resolve them, and that the drugs, if you see them through this lens of being tranquilizing drugs, there's a role for them, of course, and you can also see how they can have harms. So I guess broadly speaking, I'll quote Robin Murray. I think you should try to find the lowest possible dose for everybody, and for some people that might be 0.
Oh, okay, and thank you. And one last question. Sometimes I'm disturbed that the deprescribing becomes a moral crusade, and people who remain on their medications are somehow inferior human beings because they still require medication, and I'm concerned about that. It should not be that way. I think it's very important when talking about deprescribing to see that in the context of shared decision-making. So at one extreme, you still have too many psychiatrists who will not talk about it. And if the patient brings it up, they'll say, no, it's very dangerous. You're not going to do it, and I'm going to sleep well at night. And which is an important consideration for us people. But and at the other extreme, where you have a psychiatrist who's saying, well, what? You're still taking it 6 months after you started? What is your problem? And we have to realize, we have to conceptualize this, I think, as a legitimate option. As you have shown so well, it is evidence-based. And there's a good way of doing it, a proper way of doing it, an improper way of doing it. And this is something which psychiatrists need to know to raise as an option when working with their patients, and to respect it when the patient says, hey, I'm doing fine, don't rock the boat. If it ain't broke, don't fix it.
Yes. So I agree with you, Pesach. You know, I don't think it's a moral, you know, I don't think it should be a moral crusade. I don't think it's a moral question. I don't think people are better because they're off the drugs. You know, I certainly don't push people. So, for example, I run this clinic where people, we help people to stop their drugs. Occasionally, an overzealous doctor will send us a patient that they want off their drug, a benzodiazepine, because it's, you know, a bad drug in the UK. And the patient, you know, starts crying in my clinic, I don't want to come off the drug. I tell the doctor off in that state, in that situation. I'm not there to enforce coming off the drug. You know, we want to help people that want to come off their drugs to do it in a safer way. I do think it's important that that decision is informed. So I think a lot of people are not very informed about what their drugs do, about how effective they are, how harmful they can be, and what trouble you can get coming off the drugs. I think often people say, I know I need my drugs because when I come off them, I feel terrible. You know, and there's always the possibility that they're mistaking withdrawal effects for a relapse. So I agree with you. You know, I don't push anybody. I don't think you're better if you come off your drugs. It's very individual. Everyone's in a very different circumstance. You know, some people tell me, look, my drugs are incredibly helpful to me. I have no side effects. Okay, great. You know, I'm very happy to hear that. I don't, you know, of course they should have the right to continue their drugs. And I write a lot of letters to doctors saying, you know, let this person stay on their drug. So I think it's up to an individual person, but I think they should be informed. So I did a lot of, you know, I think late in the piece, informed consent in our clinic. The informed consent they were not given when they started the drug, we give now years into it. And again, even if people decide that they would like to be off the drug, some people just don't have the circumstances to do it. You know, their lives are too stressful. There's expenses involved. It's not the right time for them. As you say, they don't want to rock the boat. So everyone is very individual, and there's no, you know, there shouldn't be moral judgment of people. You know, everyone is doing the best they can given their circumstances. So I'm certainly not in the role of trying to push people off their drugs or saying it's the better thing to do. I just think people should have information to consider what they want to do.
Okay, thank you. I have probably many further questions, but I'm not going to ask them now. I'll give others a chance. I do have one last comment, which is actually for Golan and for Itai, that we don't have in Israel access to enough liquid medication preparations. We don't have these alternative kinds of minuscule doses and pills. I had a patient who indeed would take out the little pills inside the capsule. He taught me how to do that because I've never seen anyone do that before. But this is something which our organization could make a really important mark by advising people on how to get a hold of this. I mean, frankly, I don't know, especially if it's not describing one of those very few medications which come in liquid form. The guy's been, let's say, on olanzapine or on Seroquel or on another SSRI, and how do I reduce it? It's very hard, especially since they rarely come in capsule form. This is something which might be a good, very helpful, productive mission for our organization to undertake, educating about it and seeing to it that these options are out there and accessible.
Can I say two quick things to that? You make a very important point, Pesach, because even doctors that are sort of on board with this will say, oh my God, oy vey, what a headache to get people off these drugs. I've got to crush tablets and count beads. It can be done. You know, it can be done. As I showed you, there's government guidance in the UK. It would be easy to have smaller dose tablets. As it happens, an Israeli company is looking at it, Teva Pharmaceuticals, the generics manufacturer. So, you know, if you could encourage them to do it, I know they're interested. All they need is a bit of a push. You know, they can see there's probably a market for it. It would make life much easier. In the meantime, you know, there are ways. There's many people around counting beads and crushing up tablets and getting liquids from compounding pharmacies. But you're right, to have more formulations would make life easier for everybody. So good point.
Okay. Thank you very much. I hope we get to talk some more, but not now. Golan, shall I go to the questions without a break,
Yes.
since it's late?
Please.
Yeah, okay.
Thank you, Pesach and Mark, for the very interesting discussion. We all enjoyed from the questions and the answers. And maybe we should pick some questions, because we have a lot of questions here on the Q&A. Maybe some of the questions can be answered by typing, or we can take a few minutes.
What I thought is I'll just go over some of the questions and have Mark answer them. Is that okay?
Yes, of course.
Okay, I'm going down. I don't know if I'll ask everyone, but I'll try to cover the ones. Maya, first of all, asks me as well as Mark, how is it that the establishment continues to say that antidepressant medication does not have any kind of addictive potential when it so clearly does? And this is true, Mark. You mentioned this early in your essay, how in your lecture, about how they used to call this discontinuation syndrome. I always thought that was funny. Like, what's the difference between doesn't heroin and opiates, don't they also have discontinuation syndromes? Or why is it they're called addiction and here it's called differently? So the times are changing, and I don't hear that term anymore. And there's much, in no small part because of the work of Mark Horowitz, that it's being called for what it is, withdrawal effects from the brain becoming addicted to these medications. Then there's another question from Yarden asks whether it makes a difference in coming off the age at which you are starting and stopping the medication. Mark?
Yeah. So I'll just quickly say something about the addiction issue. So 2 points. So one, in some ways it's academic, but I think it's worth knowing because it helps make the argument. I don't think antidepressants are addictive. What they do is they cause physical dependence. So addiction means people that craving, compulsion, injecting, stealing money to get more. That's not true for antidepressants. And sometimes people using that language, a professor will sort of laugh and say, well, that's wrong. And it sort of is technically. For example, so physical dependence is what happens when you use a drug repeatedly, and the only manifestation of physical dependence is a withdrawal syndrome. So for example, I'm guessing everyone in the audience is physically dependent on caffeine. No one is injecting it or selling their bodies to get more caffeine. But if you were to stop it, you'd get a withdrawal syndrome. So you're physically dependent on caffeine. You don't need to be addicted to something to get withdrawal from it. That's another trick they try to pull. They say, well, antidepressants can't cause withdrawal because they're not addictive. That's not pharmacologically correct. All you need to be is physically dependent on a drug to get withdrawal from it. Discontinuation symptoms is a horrifying euphemism. My joke is it's like calling a car crash a discontinuation event involving a wall. It's a euphemism used to minimize the effects. They wanted their drugs to sound differently from benzodiazepines and opioids. How do institutions get away with denying it? That's a much bigger question, because there's no pressure on them to change anything. There's been a bit of a change in the UK. There's a bit of backsliding now. America, there's no recognition. I don't know what it's like in Israel, but it's very upsetting to psychiatrists to hear that what they're doing isn't quite right. So I think there's a lot of cognitive dissonance and a lot of resistance to this. The question was, what age do you start the drugs and stop them? What effect does that have? Look, there's not a lot of research. What's very clear is the longer you use the drugs, the harder it is to stop. People who use the drugs for weeks generally have no trouble. Not always, but mostly. People who use the drugs for 10 years or more almost always have trouble. Whether it matters whether you started at 15 or 35, I'm not sure. People have this idea, if you start them younger, your brain is more plastic and therefore more affected by the drugs. Could be. It's also more plastic, so it's easier to stop the drugs. So I'm not sure. There hasn't been a lot of research saying one way or another. What I do observe is it's easier for younger people to come off the drugs than older people. And I think it's because it's like running a marathon. It's easier to run a marathon at 25 than at 75. And so it's easier for people to recover from the effects of these drugs when they're younger. But look, everybody has a chance as long as you're doing it slowly enough not to get into trouble.
Okay, that's good. There's a question to me about whether you have venlafaxine in capsule form in Israel, and you do. That's I believe it's the Effexor brand, which comes in capsules. And the Yaakov Kranz asks, are there certain medications that should not be split or cut due to their special form of absorption and uptake in the intestine, or we cannot cut them?
Yes. So it's slightly complicated to simplify it. So yes, some long-acting drugs shouldn't be cut because there's an issue with dose dumping. That if you meddle with the way the drug is delivered, it can all come out at once, and that can be bad for you. But for most long-acting drugs, all that happens if you split them is you lose some of the long-acting properties, and they become the short-acting version. So you take an extended release drug, if you crush it up, all you've got now is an instant release version of it, which generally means you need to take it more often. So it's not a complete no-no. It's worth asking a pharmacist. In some ways, it's simpler just to deal with instant release drugs because then you know what you've got. So that's a good consideration to take into account.
Okay. Someone wants to know whether it's better to weigh the beads or to count them in the capsules.
Right. Getting into the nitty-gritty, which is where this all comes. The answer is it's probably more accurate to weigh the beads if you have a very accurate balance. So it really depends on how heavy the beads are and how accurate your balance is. The reason why it can be more accurate than counting is because beads are different sizes. And so when you get down to very low doses, to some degree, at higher doses, it doesn't matter which one you do. At lower doses, it's probably more precise if you've got a very precise weighing machine because the beads start to have different sizes. And so it's harder to be accurate at that point. Although some people, what they do is they'll count small beads, medium beads, and large beads to try and be more careful. So it depends on how obsessive you are and how much money you have to spend on a weighing machine. So both are reasonable options, and lots of people do either one with their drugs.
Okay. Someone asked whether after 30 years of getting over 30 years of being on antidepressants, most recently paroxetine 20, is there a chance of reducing and getting off of that?
Look, I think the answer is yes, if you're very careful. So, I'm just one example. I've been on these drugs for 21 years. I was on multiple drugs at the height of my psychiatric career as a patient. I was on 5 psychiatric drugs at the same time. And today I'm on the last crumb of one drug. I have certainly seen patients who've been on the drugs for decades. Being on paroxetine is a very high-risk drug. Decades puts you in a very high-risk category. So, it's definitely not going to be easy. What I see is if you go slower, it's easier. So, if you try to get off quickly, I'm sure you'd be in a lot of trouble. If you went off at 2% per month, very carefully over years, you'd have a reasonable chance of doing it. So to me, everyone can find having seen now quite a few thousand patients, everyone can find a rate that they can handle. It just can be very, very slow.
Okay, but there's a possibility. Good. The question is, if somebody comes off the drug a bit too quickly and there are withdrawal symptoms, will the symptoms resolve at a certain point, or are they going to be there for the rest of his life? Unless they go back on the drug, someone wants to know. So, good question.
Good question. So this is a bit complicated. So I think there's also a question there, which is something about yes, if you have trouble, should you go back up straight away, or do you wait? And this is sort of
yes, yeah. You've gotten further ahead than I have. Oh, good.
I've been flicking my eyes around it. So withdrawal effects are a complicated business. So what I'll give you my analogy, even though it takes a bit of time to say. the analogy that I use is deep sea diving in the bends. So I think this is a good analogy for coming off these drugs. When you go deep sea diving, which I'm much too scared to do, but people do it, you go down the bottom of the ocean, there's high pressure and it pushes gas into your vessels. And if you shoot up to the top of the sea after being down at the bottom of the sea very quickly, the pressure drops, gas pours out of your vessels, and you get headache, dizziness, muscle pain, joint pain, what's called the bends, or a decompression illness. And what are you told to do to avoid it? You're told to come up and get used to new levels of pressure. When you're used to it, then go up a little bit more, get used to the levels of pressure, then go up a little bit more. In other words, you're supposed to taper off the pressure. And if you get into trouble, what do? So you go back down again, get used to levels of pressure and come up more slowly. Although they often do it in a special chamber on land because it's too dangerous to do in the sea. I think it's very similar to coming off drugs. Withdrawal effects to me are a sign you're going too quickly for your body to handle, like the bends. So it's a sign to go slower. Now, if those symptoms are mild, you could just pause for a bit, or maybe you can tolerate it. But if it starts to become more severe, what would you think about the guy coming up from the bottom of the sea who's starting to get very severe symptoms? Should he push through it? In general, you shouldn't, because you can get very ill with the bends, like you can get very ill with withdrawal symptoms. So to me, when you start to get moderate to severe symptoms, it's a sign you're pushing your body to its limits, and the nervous system is not something to play with. You don't want to get akathisia. You don't want to get protracted withdrawal symptoms. It's better to take the message and to go more slowly. And that's also another reason. This bleeds into another question, which is people say, should I take other drugs to try to deal with withdrawal symptoms? Think about the guy getting the bends in the sea. If he said, I'm starting to get the bends, should I use a benzodiazepine or quetiapine or alcohol to mask my symptoms? You'd think, this guy's not very clever, because he's going to get into a lot of trouble from the bends that he's suppressed temporarily with these drugs. He should take the note from his physiology to go slower. And I think the same is true with withdrawal effects and psychiatric drugs. Take the feedback from your physiology and go slower. So, if you have withdrawal symptoms, this person's saying, will they last forever? And you need to reinstate the drug? Look, it depends. When people go away for a trip and they forget their drugs for a few days, if you go back on the drugs, it always makes it better, almost always in a few days. If you get into very big trouble, sometimes reinstatement doesn't help things. So I've seen that a few times. That's what protracted withdrawal syndrome is. It's people that are in so much trouble. Again, think about the bends person. You get into so much trouble from this gas pouring out of your vessels that going back down doesn't really help you. You've now just caused, damage to your tissues. And I wonder if the same thing is a bit true for coming off psychiatric drugs. If you do it too quickly, it's very hard to put toothpaste back in the tube. And I think people can have trouble that goes for long periods of time afterwards that is not solved by going back on the drugs. So I'm giving you a slightly complicated answer. I would basically say withdrawal symptoms, if they're mild, okay, that's fine. You can get through that. Once they start to get more severe, I think that's a message from your body not to go too quickly. And it's better, not to push through that stuff. In my clinic, the sort of word we use is tolerable. If you have tolerable withdrawal symptoms, that's okay. The sort of symptoms you can work around, you can fulfill your roles as a mother, father, uncle, brother, sister, school teacher. And once it starts to become, quite severe, that's a sign to go slower.
Okay, and it's getting late, so I'm not going to have time for all the questions, but some did ask about stimulants which people take for perceived ADHD, amphetamines and Ritalin. What have you tapered that?
So I do have much less experience with tapering stimulants, although I've come off stimulants myself. I'd say two things about it. One, it's generally easier to come off stimulants than other psychiatric drugs. That's my observation. Most people, I'm not saying it's easy, but I don't think it's the same difficulty as coming off antidepressants or antipsychotics. And the same principles arise. It's the same curve. The effects of small doses are larger than you would think. And so it makes sense to come off by a proportion of your dose. I use as a rule of thumb, 10% per month. Probably for a stimulant, you could do quicker than that, but that might be a rule of thumb. And I can also see a spattering of questions asking for this drug and that drug. That's my answer to everything. If you've been on a long-term drug, coming off at about 10% of your most recent dose per month is a good starting point. If you have a lot of trouble, you might go down at 5% per month. And if you're having an easy time, you might go up to 15%. That is a generally rule of thumb. That's the range. People have a lot of trouble, 5% per month, so it gets smaller and smaller. People that have not much trouble, 15% a month. That's what I sort of use as my one sentence answer to that.
Okay. Golan, I think we're over time already, and we need to end. There are some more good questions which we're not able to get to. But wow, it's wonderful speaking with you, Mark, and that I hope we'll have more opportunities.
Thanks, Dr. Lichtenberg. It was very nice talking to you too, and thanks, Golan, for organizing.
Yes, thank you, Pesach and Mark, for having with us this conversation, and thank you all for being here. אנחנו נמשיך לנסות ככה לראות, אולי ניקח את השאלות ונשלח אותם, או אני לא יודע אם נוכל לענות על כולם, יש פה הרבה שאלות, אבל תודה לכל מי שהשתתף בוובינר, ואנחנו כן, we have few events soon, בשבוע של עושים נפשות, אנחנו נקרין סרט ונעשה פאנל, זה יקרה בתחילת דצמבר, and we're working for doing a seminar for psychiatrics, for professionals, so and we have this seminar for therapies, for psychotherapists, and we hope to see you in our next events. And please support us if you can. You can support us by donating in our website. There is a link. כל תחומה שלכם עוזרת לנו לגדול ולעשות עוד דברים. אנחנו מתחילים עכשיו פרויקט של מחקר. We are starting now a survey in Israel, Mark. So it will be very interesting to see what we will get from this survey. Yeah.
A survey to publish, or just to see what people's views are about these drugs?
We want to publish like a review about this. Yeah.
Right. Very interesting.
Like a report. Yeah. אז תודה לכל מי שהגיע, and thank you again, Mark, for being with us, and Pesach also. ותודה רבה ליעל כהנא שתרגמה. Thank you for translating everything. Okay. So, אנחנו נשלח הקלטה לכולם כשהיא תהיה מוכנה. So thank you, Mark. Have a good night. לילה טוב לכולם. תודה שהייתם.
תודה רבה.
תודה רבה. Thank you very much. לילה טוב.
טוב, תודה.
תודה רבה.
רבה. היה מרתק. תודה.
תודה. פסח, תודה רבה.
בכיף, תודה על ההזמנה.
משהו קרה על המסך שלי.